My name is Nan Chen. I'm one of the breast medical oncologists. And this morning, we'll begin a series of discussions about race, ethnicity, and healthcare disparities and breast cancer. And this is our agenda today. So let's get right into it. So this figure from the American Cancer Society depicts the rates of national breast cancer screening from the 1980s up until 2018, which unfortunately increased dramatically with the most current utilization by white and Black patients of nearly 70%, followed by Hispanic and finally Asian women with the lower rates. This graph captures women over the age of 40 who've received at least one mammogram in the past 2 years. And while this initial data does look promising, a deeper look reveals that there are still many disparities. If we separate these patients into various subgroups, there are important distinctions. Immigration status of being here less than 10 years, education of less than high school, and income level relative to the federal poverty level, and insurance status are all important factors that influence rates of mammography. On the right, local data specifically for Illinois and Indiana show us, unsurprisingly, that uninsured and underinsured patients get screening mammograms at a much lower rate than insured patients, and Black patients and other minorities are more likely to be uninsured as compared to white patients. This is data looking at rates of mammography in 2012 and 2020, notably the percentage of women who did not receive a screening mammogram. It decreased, but most significantly in Hispanic and Black patients. And one large reason for this was the adoption of the Affordable Care Act and the expansion of Medicare and Medicaid. But if we look historically, since the 1940s, rates of screening mammograms have historically been poorer for Black populations across the age spectrum and younger Black and Hispanic women. Only recently, in the last 5 years, have these numbers kind of become more equal. The type of screening mammogram patients receive is also important. Thankfully, here at the University of Chicago, we use tomosynthesis in all patients, but this is a study conducted at 63 breast imaging centers over a 4-year period. The study showed that the proportion of women who received more than one mammogram over this 4-year period was greatest in white patients and significantly lower in Black patients. Furthermore, white women were more likely to have a tomosynthesis compared to Black women, despite Black women having typically more advanced breast cancer on screening. And in conjunction with this, thinking about high-risk patients and screening with MRIs, there's data that shows that white women are utilizing MRIs for high-risk screening more so than Black and Hispanic women too. I wanted to briefly also review some of the epidemiology of breast cancer in the United States. This graph shows the incidence of breast cancer from 2014 to 2018 within racial groups, with non-Hispanic white followed by Black patients having the highest incidence. However, when we look at mortality as opposed to incidence, despite the decreased incidence in Black patients, the mortality of breast cancer is greatest in this population as compared to whites and other racial groups. We also know that the subtype of breast cancer varies by race. In this comparison of white patients and Black patients, we see that a smaller proportion of Black women will be diagnosed with, your luminal cancers, ER-positive, HER2-negative disease, and a larger proportion of Black patients will be diagnosed with TNBC, which tends to be more aggressive. And lastly, the stage at the time of diagnosis is different with Black women as well, being more likely to be diagnosed with stage 2 and stage 3 disease compared to Black women. Another retrospective study utilized 18 SEER registries and found that African American women were 30 to 60% more likely to be diagnosed with stage 2 to 4 breast cancer than white women, and 40 to 70% higher risk of stage 4 breast cancer at diagnosis across all subtypes. I wanted to highlight the work that we've done here over the years at the University of Chicago. These graphs come from data collected through the CHIMEC cohort, which Dr. Olopade has been leading since the 1990s. On the left is the probability of death over time, and the curves on the right show probability of death or recurrence. We can see in every subtype of breast cancer, Black women have a higher risk of mortality compared to white women. Interestingly, most notably in the ER-negative, HER2-positive patients. The disparity between Black and white patients was strongest in terms of breast cancer-specific mortality, while relatively weak in terms of time to recurrence. And this may be related to the fact that risk of recurrence is related to the first-line treatment, while breast cancer mortality is affected by subsequent lines. And maybe the effect of racial disparities are compounded as patients are treated in their course of breast cancer. And lastly, data not shown here, but in other papers shows that there are even racial differences in our ability to achieve a pathologic complete response in patients who receive neoadjuvant therapy. And there may be underlying genomic mechanisms that can help us better understand those differences and disparities further. I think many of us in the last year or two encountered patients with newly diagnosed breast cancer who delayed or didn't have their screening mammogram during the pandemic. On the left is data out of Washington State that showed that while there was a universal decrease in breast cancer screening, there was a significantly increased decrease in non-white groups, with the greatest decrease in Hispanic patients. And on the right is data from Columbia and New York City depicting the likelihood of having a diagnostic or treatment delay related to COVID-19 in breast cancer patients, showing that Black patients had a 1.5 times increased likelihood of treatment delay, and Asians over 3 times likelihood. Insurance status did matter, and having either Medicare or Medicaid led to having more treatment delays compared to patients with private insurance. Here at U of C, we sent surveys to participants in the CHIMEC cohort to evaluate their COVID-19 experience. Unsurprisingly, there was a statistically significant increase in feelings of isolation across both white and Black women. However, in looking at other aspects of health, such as financial toxicities, there are differences between Black and white women, notably that Black women were more likely to lose their job during the pandemic or have reduced wages, lose their health insurance, have difficulty paying life expenses, and difficulty getting food, reflecting really how important the social determinants of health can be in our community. So let's talk a little bit about that. We know that there are many factors outside of physical health that contribute to our patients' well-being, many of which are listed here, and this is certainly not a complete list. Health literacy, cultural and community relationships to the healthcare system, logistical concerns such as transportation difficulty and financial toxicity all contribute to delays in diagnosis. I'm just going to highlight that regular visits with a PCP has been shown to be one of the biggest determinants of appropriate breast cancer screening, and an area certainly that we can work on with our African American patients in Cook County. So what are some social determinants of health, and specifically in how they relate to rates of screening mammography? This data comes from women registered in the Breast Cancer Surveillance Consortium registries from 2012 to 2017. And I've pulled data here from urban environments rather than rural, since that's more applicable to us. In this study overall, about 4% of women in the urban area did report a barrier to mammography utilization, with the most common reason being financial, and second to just other life responsibilities. African American and Hispanic patients in both urban and rural environments were more likely to report increased frequency of at least one barrier, and increased number of barriers such as those listed above. Other social determinants that were significant included lower median income of the community they live in, higher median cost of health insurance, and actually percentages of local residents with internet access, with higher percentages maybe reflective of a more financially secure community. So why are some of the reasons this to be the case? You know, Black women can perceive themselves to have lower risk of breast cancer, and thus a lower perceived need for even going to a mammogram and delays in seeking medical attention. There are a lot of fears surrounding the mammography process among Black women. They have a fear of being disrespected by clinicians or not having their health concerns appropriately addressed, the pain and discomfort during the mammogram, embarrassment, lack of privacy. They may have had bad experiences with cancer in their family, and they fear losing significant others, as well as having abnormal mammogram results or the incorrect interpretation of their mammogram by their physician. And while there are similar rates of BRCA1 and 2 and other pathogenic mutations associated with breast cancer, Black women are less likely to seek genetic testing for a multitude of reasons. such as lack of knowledge of what genetic testing is, a lack of physician recommendation and referral to genetic counselors, the high costs or financial toxicities associated with genetic testing, limited access to healthcare, medical distrust, as well as a fear of discrimination. So we have these patient navigators, and some of the goals of navigation are shown here. So there are many things that our navigators do, including coordinate care, provide patient education, provide psychosocial support to the patient and their family to identify specific barriers to care and provide resources for patients and their caregivers, as well as advocate for their patient to reduce, discrimination and as best they can in the medical community. And while we have navigators who can specifically help to address many of these things, I think we are all responsible for supporting our patients in their breast cancer journey, which could be done. These are some support principles in navigation that I think serve as a good reminder for all of us every time we have a patient encounter. And these include to empower the patient, reframe the conversation, reduce patient isolation, offer logistical support at the cancer program, connect patients with support in the community, and to collaborate, such as we are now, in the interest of patients. I'll end this presentation by discussing a couple studies that also investigated kind of time to diagnosis from initial presentation. I think that's one of the big projects that's being done within the SPORE and within this quality improvement project is looking at our personal delays to time to diagnosis and also delays to treatment. This is a study that was done at Harvard. On the right, you can see that this is for symptomatic women. Non-Hispanic white women in green were diagnosed earlier compared to other races. And you can see some of these women were not even diagnosed for nearly a year out, since they began having symptoms. And time was defined as time from initial symptom of breast cancer to the date of breast biopsy that had a positive, cancer diagnosis. And in the first month, only, 52% of women received their diagnosis, but only 42% of Black women did. And the same analysis was performed for women with abnormal mammograms, so asymptomatic. And while the discrepancy was less than in symptomatic women, it still persisted. And then similarly at Emory in Atlanta, they had similar findings in looking at over 700 women who underwent breast cancer screening and were then later diagnosed. There was a significantly greater delay in Black women compared to white women, of 42 days in Black women as compared to 26 days in white women. This was race agnostic in terms of patients who were uninsured and resided in lower socioeconomic status neighborhoods, but they unsurprisingly also had longer delays.